Welcome. My name's Prashanth, and welcome to the first session of the Basic Neurology Q&A. I am incredibly excited, and I'm primarily incredibly excited because I got this to work. Well, I think I've got it to work. This is the first time we're doing a stream. This is the first time I've used such a setup. So if there are technical issues, so be it. We will overcome them. We have time. It's a Friday night. I have nothing better to do. Actually, I do have lots of better things to do, but I'm excited to be here to do some neurology. So right now, we'll let a few people kind of come in small amounts. I don't know who will be out on a Friday night wanting to learn some neurology, but with exams coming up, hopefully people do want to learn some neurology. So I'll start off by saying these sessions are meant to be essentially a way to answer any gaps you might have in your knowledge, any particular issues you might have about neurology in terms of the exam, clinical skills through your exam, but even patients you might have difficulty with managing on the ward, or you just have knowledge gaps in terms of what you want to learn. I want to preface all of this by saying that probably been on mute this entire time. So I'll start again. I'll say welcome to the Basic Neurology live stream. My name's Prashanth, and thank you so much for joining. And I'm so excited to be here. I'm so excited that this is up and running and working. And I know that it's a Friday night, so if you are joining, thank you for joining. What we will do today is essentially try and go over questions you might have, primarily for the exam. Things that you're studying about, you don't quite understand, there's a knowledge gap that you want to try and overcome, and we are here to try help you as much as possible. Oh, I wasn't on mute, fantastic. And we'll try and take this as an approach to, allowing you to learn, but I want to preface it by saying this is purely educational, and please don't feel like I'm answering actual patient referrals for you, okay? Because obviously that's not how this works. But this is purely educational, how you would think of working up these patients, but obviously talk to your local neurology teams, talk to your local neurologist to get some actual proper medical advice. And for anyone who's out there who's not a doctor training, again, this is purely educational, not trying to help diagnose patients here or give them the correct advice. Everyone's different in their own way. So here we are, and what I initially hoped was that people would send in questions beforehand. I would put something together, a nice little presentation, and present it, but the reality is no one has sent a single question in, and that's fine. So we'll just do it purely from the chat menu. We'll pick up a question. I'll try explain it as detailed as possible. I'll try bring up some of my slides. Bear with me if I'm trying to do that, and then essentially we'll feel free to ask me questions back, and we'll kind of do that as we go along. So the first question comes from Escobar Cornelius. Thank you. And the question is, what are the differentials for foot drop? How do you work up foot drop? So we've talked about this before in the course, but for those of you who may not have come, let's just talk through the ways we think about foot drop. So a foot drop is essentially someone has the inability to dorsiflex their foot. So with their inability to dorsiflex the foot while they're walking, they aren't able to clear the foot up. When you're walking, there's actually a process where you are inadvertently dorsiflexing your foot. If you weren't doing that, if you weren't keeping some amount of power and tone in that dorsiflexion position, the foot would drop, your foot would actually hit the ground and it would kind of catch. So that's the first presentation people actually notice. They're walking and they notice a quite small catch with their foot. The toe is actually hitting the ground. Sometimes they may not notice this until they are running, until they're exerting themselves. They're doing something that requires a subtle amount of power to be there. So that's usually the presentation. So we need to think about this as anything that can cause dorsiflexion weakness can cause a foot drop. So when we think about localizing anything in the nervous system, we always need to think about, is this central or is this peripheral? So we can divide that into, is this an upper motor neuron problem or is this a lower motor neuron problem? If this was an upper motor neuron problem, then we would expect to see upper motor neuron signs. And so this is some sort of dysfunction that's occurring in the corticospinal tracts. So these are tracts that start in the frontal cortex, in the motor cortex, and they make their way down through the spinal cord, and they synapse with the second order lower motor neurons in the spinal cord, and then make their way out to the peripheral nerves. So if we think of the prototypical kind of patient that has an upper motor neuron problem, think about what posture they're in. So when they have let's say a stroke as an example, and you look at these old textbooks of patients who have strokes, they've got a posture where their upper limb is in this position. And the reason it's in this position is because they actually have extension weakness. And so because of that extension weakness, they have flexion predominance, and because of the spasticity, they get stuck in that position. In the lower limbs, now I can't show this to you, but in the lower limbs, their legs completely straightened out, okay, and it's completely all the way out. So if you think about that in that situation, what's occurring there is there's significant flexion weakness in the legs. So you can get a foot drop because there's dorsiflexion weakness that occurs with an upper motor neuron problem. And usually what will happen is you will have upper motor neuron signs with that. So the first thing you're doing on examination is you're trying to differentiate this dorsiflexion weakness. Is it peripheral or central? If it's central, if it's a first order upper motor neuron problems, we should see upper motor neuron signs. So what is that? That is TPR, tone power reflexes. And so we can look at tone. Is there spasticity in the leg? Is there spasticity in the foot? Now, spasticity is velocity dependent increase in tone. So if you were to just wiggle the foot or just move it slowly, you may not find any spasticity. But if you were to do it quickly, that's when the spasticity kicks in. So specifically with the foot or the lower limb, what you do is you get the patient lying down and you wiggle the knee. When you wiggle the knee, the foot should kind of jiggle back and forth, and that's normal. If there is increased spasticity with that movement, you might see that it's a little bit stiff and it doesn't quite move. It's like a plank. Then what we want to do is gently move the knee up and down, and then very quickly trying to bring it into that flexion position. And in a normal situation, you should see the foot dragging on the bed. When someone has spasticity, that increased velocity that you're giving with the knee, suddenly the foot comes off the bed and you know there's increased spasticity in the leg. So we look for spasticity. The next thing we look for is power. We're looking for dorsiflexion, plantar flexion, etc. We do the full exam, but we look specifically for that pyramidal pattern, and we look for weakness in dorsiflexion. We then look at reflexes, and in upper motor neuron, they are elevated. They go up. So we're seeing hyperreflexia in the foot, and we're seeing hyperreflexia in the knee, and then finally we do the plantar response, and we want to see that the toe, if it goes up, is an upper motor neuron problem. If it goes down, it's a lower motor neuron problem. So if someone comes in a foot drop and they've got hyperreflexia, spasticity, and an upgoing plantar, we can automatically localize it to the central nervous system. So that means brain, that means spinal cord. If it doesn't come, if we do the exam and it's the complete opposite, we have no spasticity, there's decreased tone, the reflexes are gone, so down, and the plantar is going down. So everything goes down in lower motor neuron and everything goes up in upper motor neuron. If everything goes down, then we know the problem's in the periphery. So always when you come to a patient with a neurological problem, the first question, is it central, is it peripheral? That's the first thing we need to figure out. Once we figure that out, we can then delve into a deeper differential diagnosis. So let's focus on upper motor neuron because that's the first thing we're thinking about. So I think I've told this story before, but I had a patient when I was a registrar, and she'd come in with essentially a foot drop. Okay, essentially had come in with a foot drop, and that was her only neurological problem. I don't know why we admitted her, but we did. And when you examine her, she had significant dorsiflexion weakness. She did have plantar flexion weakness as well. I must admit this is about 7 years ago, so I can't remember the exact examination, but she did have an upgoing plantar. That was the only clue that was there. Her reflexes were kind of normal. Sensation, interestingly, she had lost proprioception, vibration, and pain and temperature. So complete loss of sensation in the foot. So the first question is, this is a foot drop because she's lost dorsiflexion. She's dragging her foot. To a degree, plantar flexion is weak as well, so there's a little bit of a significantly weak foot. But where do you localize the lesion? So really, it's upper motor neuron. It could be spine, it could be brain, and the clue here. And again, we do this in the full course, and if you have questions, I can go into this in more detail. I'll bring up some slides, but If you remember the sensory pathways, pain and temperature and proprioception and vibration, spinothalamic and dorsal column, these two pathways, they go in different parts of the spinal cord. They traverse in different parts on different areas. And the only place they come together and then move forward is the thalamus. So if someone has all sensory modalities lost in one limb or one area, then the lesion must be above the thalamus and onwards. So it couldn't have been a spinal cord lesion. So I could say fairly confidently that this was a lesion from the thalamus all the way higher, maybe into the cortex as well. And we did an MRI scan, and there was quite a few strokes there. She'd actually had multi-territory strokes, and there was just one stroke that had essentially knocked off the foot region, that had knocked off motor and sensory, and so we were able to localize it to the central nervous system, but specifically to the brain, and specifically above the thalamus. Now, we can also get foot drops in spinal cord lesions. Very unusual, but can happen. We can also get foot drops in motor neuron disease, and it's not something that is, I wouldn't say, motor neuron disease is uncommon, and it's an uncommon presentation, but I've probably seen about 2 cases of someone young presenting with a progressive foot drop, upper motor neuron signs, and we've done nerve conduction studies and we've found motor neuron disease. And it's sometimes the kind of first presentations in these cases. So something to consider and think about as well. So those are generally the upper motor neuron causes. Now, we've localized it. I haven't necessarily given you all the differentials, but essentially anything that can cause disruption to those tracks can potentially cause a foot drop. As a neuroimmunologist, I certainly see a lot of MS patients who have foot drops. They also have other complex neurology at the same time, but it's this concept of dorsiflexion weakness. And it's a common thing they'll say is, you take a history and you say, do you have any difficulty walking or with mobility? And they'll say no. And a subtle question you always ask is, what about running? Now, not everyone runs, not everyone jogs, but some people, and I do remember one patient saying that when I ran and I did marathons, and when I got to the 10th kilometer, I'd notice my foot catching as I ran. And it's probably this kind of Uthoff's phenomena. He's getting more and more heat, he's getting slower and slower conduction, and the foot's just starting to get a little bit of that dorsiflexion weakness and catching. So you can certainly see it in a subtle way as well. Let's focus on lower motor neuron, and I'm actually going to bring up a slide here, primarily because it just becomes easier for me to teach. So bear absolutely with me. Like I said, this is the first time I have done any of this YouTube shenanigans that the youngins do these days, but give me a second and I will bring up the peripheral nerve cheat sheet for all of this neuroanatomy. Here we go. Okay, close that. Open that. Here we go. Yep. That is not a foot drop, so bear with me. That is actually the father of neurology, Charcot, just doing his thing in 1860 Paris. Okay, here we go. Hopefully everyone can see that. I will move myself up into the corner here. So when we think about foot drop in the peripheral system, what we're really trying to do is trying to localize where the problem is coming from at the different levels of how the peripheral nerve actually functions. So if we think about how the peripheral nervous system starts off, it comes off through radicular nerves. These are the big nerve roots that are coming out of the spinal cord. They're making their way through the foramen, and they're making their way down and then mixing up in the lumbosacral plexus, and that's a way of building functional reserve by spreading a lot of those kind of nerve fibers. And then it makes its way down as the peripheral nerves. Now, if we go to the neuroanatomy of the posterior system, and if you remember this, sorry, give me a second. Here. So if we think about the sciatic nerve, so the sciatic nerve is this gigantic nerve, and it gets nerve fibers from L4, L5, S1, S2, S3. All of these nerve roots provide fibers to the sciatic nerve. Now, if you can recall, the sciatic nerve itself is really just two nerves bundled together with some glad wrap. So we've got the common peroneal nerve and we've got the tibial nerve, and they're put together, they're bundled together into one sheath, and we call that the sciatic nerve. The sciatic nerve makes its way down the posterior aspect of the thigh, and then it splits into the common peroneal and the tibial nerve. Now, the common peroneal nerve is the more important nerve. It comes out, splits off at the knee here. It's the nerve that controls dorsiflexion. So it's the nerve that actually brings that foot backwards, and it's also important for eversion. Now, the tibial nerve does the complete opposite of the common peroneal nerve. The tibial nerve plantarflexes. It pushes that foot down and it inverts the foot. So these are two nerves that are kind of at agonist-antagonist with each other. But interestingly, they derive from the same sciatic nerve. So when we think about someone who has a foot drop, the first question we need to ask, is it coming really high up from the radicular nerves? Or is it coming from the sciatic nerve? Or finally, if it's not the sciatic nerve, is it coming from the common peroneal nerve? And those are the three locations we're trying to make the localization. And once we localize, then we can figure out our differential diagnoses. So remember, in neurology, your examination tells you where the lesion is, and your history tells you what the lesion is. So the first thing we need to do is localize, and that's through our examination. And after we localize, we can go back, get a clear history, figure out the tempo, the comorbidities the patient might have that contributed to this potential pathology. So let's move back to our simple nerve root versus sciatic versus common peroneal. So when someone comes in with a foot drop, it can either be from the L4, L5 nerve root, it could be from the sciatic nerve, or it could be from the common peroneal. Now, the way to differentiate that is by looking at eversion, inversion, and your ankle jerk. So let's start off with the lower section, the common peroneal nerve. So the common peroneal nerve, like I said, splits off from the sciatic nerve. It makes its way around to the anterior part of the leg, and it gives innervation to provide dorsiflexion as well as eversion. So if you get a common peroneal nerve palsy, you will lose eversion. You will lose dorsiflexion. You will get a foot drop. Do you keep inversion? Absolutely, because what does inversion? Remember, it's the opposite of the common peroneal. It's the tibial. There's always this competition, so it's going to be the tibial nerve that's causing the inversion. Tibial nerve will be fine, inversion will be fine. Ankle jerk is also done by the tibial nerve. It's not done by the common peroneal nerve, and it's done by S1, S2 in terms of nerve roots. So if inversion is preserved and ankle jerk is preserved, then it is a common peroneal. It is the most distal part of the actual process. Now, if the patient comes in and they've got a sciatic, so slightly higher than the common peroneal, they've got a sciatic nerve palsy, well, they will lose both common peroneal and tibial. Remember, the sciatic is just those two nerves put together, wrapped in glad wrap. Now, sciatic is really common. This is not sciatica. This is a sciatic nerve palsy. So you'd have to have a significant trauma to dissect or denervate the sciatic nerve. So in the process, you have a completely flaccid foot. Absolutely nothing works whatsoever. So eversion is gone, dorsiflexion is gone because of common peroneal. Inversion is gone, as well as plantarflexion because of tibial, and the ankle jerk is also gone because of tibial. Now, the last one is that L4, L5. So I'm not going to go into the complexities of the radicular nerves, but L4, L5, the common thing here is L5. L4, L5 is inversion, and L5, S1 is eversion. So the L5 leads to a loss of eversion and inversion together. Your ankle jerk is preserved because of S1, S2. So if we use this algorithm, or it's not really an algorithm, a tick box, we can try and localize where the lesion is. And the simplest way of doing it is just saying, if the ankle jerk and inversion are preserved, then it has to be the common peroneal because tibial is safe. If sciatic is involved, you lose everything below the knee. There's nothing that works below the knee. All sensation is gone, everything's gone, nothing works. And if eversion and inversion are gone, then it's L4, L5 with the ankle jerk. So now once we actually localize the problem, we can think of the differential diagnoses. So if we have an L4, L5 problem, then we think foraminal stenosis, we think radiculopathy, we think whether there's something in the lumbosacral space that's compressing the nerve like a disc, or is it a tumor, or is it a plasmacytoma, or something along those lines. We can also think of the sciatic nerve. Usually that's trauma. Like, honestly, to have a full sciatic nerve palsy, it's usually trauma. Common perineal is the classic compression. So someone's put too much pressure on the common perineal because it's sitting right next to the knee. In my little diagram, I'll show you, it's sitting right next to the knee, and there's that compression there that occurs, and that leads to a common perineal palsy. And the way you can also go about to localize this as much as you possibly can is to do nerve conduction studies. So if it's a central nervous system problem, then we can do an MRI scan of the brain, and we can do an MRI scan of the spine. If we think it's common perineal or sciatic, we can do nerve conduction studies. And if we think it's a foot drop from L4, L5, we can do nerve conduction studies there as well, because the motor is involved and we can localize it. Now, sometimes if you've localized it more to L4, L5, maybe sciatic, you can do imaging. So you can do lumbosacral MRIs to look at the nerve root as it comes out, see if there's any compression. Sometimes you can even do further tests to look at the sciatic nerve as well. And certainly you can do thigh MRIs and look at the sciatic nerve as it makes its way through. So hopefully that's been a way for you to think about the differentials and the localization of the foot drop. Escobar Cornelius, is there any other questions, or do you want to go over any other things about that? Was that clear for you? Escobar Cornelius has left the chat. Okay. And so I'll just ask anyone else, if anyone else had any questions about foot drops, or how to localize foot drops, nerve conductions, or a specific case. Okay. How to distinguish Parkinson's versus Parkinsonism. So this is from S. Monaco. So Parkinson's, let's call that idiopathic Parkinson's disease. This is typical Parkinson's disease. This is, let me take off foot drop from the screen so people don't actually think we're still talking about that. So let's think about idiopathic Parkinson's as prototypic Parkinson's. Somebody comes into your room, they've got Parkinson's disease. So the first question you need to ask yourself is this true idiopathic Parkinson's disease, or is this a mimic? Could this be something else? And Parkinsonism is just a term we use to say someone has the typical features of Parkinson's, but they don't have idiopathic Parkinson's disease. So what is Parkinsonism, or what are the symptoms of Parkinsonism? So it's bradykinesia. So it's slowing of movements. And when we use bradykinesia, it's not just slowing, it's decrementing amplitude. So if I do this with my fist, and I'll put it on this way so you can see it, not only will I be slow, but the actual amplitude will get smaller and smaller. So that's a little bit exaggerated. It can be a little bit more subtler, but with each repetition, it gets smaller and smaller and smaller. So that's the first one, decrementing bradykinesia. The second things we think about with Parkinson's disease or Parkinsonism is rigidity. So rigidity is different to spasticity, and so that's kind of a good segue if we can talk about it. So we think about tone. There's tone as an umbrella term. Tone just means tone is increased, okay? But there's three different sections under tone. There's spasticity, and spasticity is velocity-dependent increase in tone. So I move the limb, there's nothing wrong whatsoever. I do it quickly, and then suddenly I feel a catch kick in. There might be normal tone, and then it suddenly kicks in and it slows down. So that's spasticity, it's velocity-dependent. Rigidity, which is what we see with Parkinsonism and Parkinson's disease, is there is just stiffness no matter how I move the limb, and it doesn't matter about velocity. That's rigidity. And then the final part of tone is paratonia. And the eponymous name for that is Gegenhalten. So never use the word paratonia, because you sound so much cooler saying Gegenhalten, and people will respect you so much more if you say Gegenhalten. So Gegenhalten, or paratonia, it's kind of hard to describe, but, well, actually it's easy to describe. It's hard to be technical about it. But have you ever taken a patient, especially an elderly patient, you're trying to do tone and they're like fighting you, and they're just kind of constantly pushing you and fighting you, and you're like, just relax, and they're getting even more kind of difficult to relax. They're just not relaxing, and they feel like they're just kind of trying to fight you. So that's what paratonia is. It's this sign that's essentially a frontal lobe sign. It's a disinhibition that's been lost. So it's disinhibition, it's not being lost, it's inhibition that's been lost. So that's paratonia. So we usually see that with frontal lobe dysfunction. We see that in certain kind of dementias, such as Alzheimer's, frontotemporal dementia, etc. So we've talked about spasticity. Let's just talk about rigidity now. So we see rigidity in Parkinsonisms. It's one of the hallmarks. So we see increased tone no matter what the velocity is, no matter how we move the limb. And especially when we distract them on the opposite side, the rigidity gets more. So usually I'll test it. I'll say, with your opposite hand, draw circles for me or paint a wall for me, and you'll find that the rigidity gets worse. So decrementing bradykinesia, rigidity, and then tremor is the last one as well. So tremor occurs in Parkinsonism as a rest tremor. That's the primary manifestation. It's a rest tremor. And so rest tremor is I relax my hands and then I get a tremor. Now, one of the caveats is don't tell the patient to put their hands on their lap and hold it like that, because you're technically getting them to posture. You really have to be relaxed, just sitting there, and then you get a rest tremor. It's 3 to 6 hertz. It's this little bit of pronation, supination. We get a bit of a thumb roll, and you can kind of see this pill rolling where this thumb is kind of moving and the pill, like they're rolling a pill. I don't know who rolls pills these days. It must have been like something that described by Parkinson himself. But look at the thumb, because actually I've seen a couple of times where, you know, you're doing a clinic, the resident comes in, they tell you the exam, they say, you know, there's nothing on exam, nothing identifiable, and you go and you see there, and you sit there, and you go in and you see them sitting there, and they've just got this thumb that's just kind of rolling away, and that's your first clue that there's a little bit of a tremor there, and it's just in that thumb, and it's that pill rolling. So those are the 3 kind of manifestations or the cardinal symptoms of Parkinsonism. Now, you can also get other things like masked faces, you can get short shuffling gait, you can get stooped posture. These are all kind of other symptomatology. So those are the symptoms, but what defines Parkinson's disease is that it's an alpha-synucleinopathy, which means it's a protein misfolding that occurs that seeds and spreads through the brain. And usually these patients get prodromal alpha-synucleinopathy symptoms. So what's that mean? That means they get anosmia, they lose their sense of smell. They also get REM behavior sleep disorder, so they will act out their dreams, they'll have really vivid nightmares, people are attacking them, they'll be punching and fighting at their dreams, they'll attack their partner in their bed, they'll fall out of their bed, and then the last one's constipation. And a lot of this can predate actually having Parkinson's disease by years. So patients who have idiopathic Parkinson's disease, alpha-synucleinopathy, most will have some sort of prodromal syndrome. And when they present with asymmetrical involvement. So there will usually be one side that has this rigidity or tremor, and they will then over a long time develop bilateral features, but there's always a start of asymmetry. They're very dopamine responsive. So if you were to give them dopamine, they would get a good response. And if you give them too much dopamine, they get dyskinetic. So that means they kind of move around too much. It's kind of like a choreo movement. So that plus no quote-unquote red flag signs will essentially give you the diagnosis of idiopathic Parkinson's disease. Technically, you need to have, and I'll bring up the criteria now, stick with me and I will go through this entire process of trying to bring up the criteria, but I will do it for you, and so I can actually show you the criteria. But essentially, you always have to have decrementing bradykinesia. Absolute must have decrementing bradykinesia. Then you can have 2 phenotypes. You can have a rigid phenotype, or you can have a tremor predominant phenotype. And you don't need to have all 3 of those syndromes, but you must have decrementing bradykinesia. If you do have decrementing bradykinesia and you then have rigidity or tremor, then you've essentially met the vast majority of the symptoms for having Parkinson's disease. Now, where is the criteria? Okay, here we go. Sorry, I'm sure I'll get smoother at this as time goes on. PowerPoint. Perfect. Okay, I'll move my screen. Oops, sorry. Hiya. There we go. Okay. So like I said, you need bradykinesia and you need rigidity or rest tremor. And you have to have no absence of the absolute exclusion criteria and at least 2 supportive criteria. Now, the 2 supportive criteria are things I've already told you about. The 2 supportive criteria are... I had it there for a second. Here. Clear improvement to levodopa. Levodopa induces dyskinesia. The tremor is rest tremor. And we've got this olfactory loss and this test that's pretty much only done in Japan. We don't have it in Australia. It's not done anywhere else. So if you've got kind of prodromal syndrome, a rest tremor, and we can give you L-DOPA and it helps, or if you give too much, it gets bad, that's a supportive criteria. What's your exclusion criteria? Your exclusion criteria is you've essentially ruled out all the other potential Parkinson's mimics, and that is difficult. Okay, but it's possible. So you need to think through what your potential Parkinson's mimics are. So the first thing we think about when we think about Parkinson's mimics are the 3 ugly sisters. Okay, multisystem atrophy, progressive supranuclear palsy, and corticobasilar degeneration. If you can look at those 3 and think how do those 3 present, and is the patient in front of me presenting like that, then essentially you run through the exclusion criteria. So PSP, progressive supranuclear palsy, they present with significant postural instability early on, significant axial rigidity, lots of falling, frontalis activation, decreased blink rate, and they have decreased vertical saccades, so their saccades are slow. So if I go up and I go down, look up, look down, you should just see your eyes darting back and forth, but there's slowing of the saccades early on, and then they lose down gaze as time progresses. And so that's your classic PSP. So if someone's coming in query idiopathic Parkinson's disease and they've got Parkinsonism, the first thing you need to do is make sure they meet that criteria and then say, do they have anything that looks like PSP? So do an ocular exam, make sure their eye movements and the vertical saccades are good, make sure they don't have axial rigidity, essentially you hold their head and you move it up and down like that. And then make sure that their mobility and stability and walking is not overly unstable. Then you look for multisystems atrophy. Multisystems atrophy is a combination of early autonomic failure. Now you can get autonomic failure in idiopathic Parkinson's disease, but it's after a period of time. It's a decent period of time of disease state, so 5 years, 8 years, whatever it might be. Multisystems atrophy presents really early. I saw a guy in clinic just the other day who had literally was admitted under, I think, Gen Med for a workup of increasing postural problems and postural syncope. And I was seeing him in my neurology clinic. He was still an inpatient, but they sent him off to the neuroclinic for something completely unrelated. I think it was like migraines or something like that. But essentially had just presented with this progressive 6-month history of having severe syncopal episodes where he's falling down, he's smashing his face, and he's having like these significant blackouts. Sometimes these occur while he's sitting, and they do this blood pressures, there's postural blood pressures all over the place, and they're dropping even without him standing. And he's got erectile dysfunction as well. And, you know, you do an examination, he's got these subtle cerebellar signs, and that's the other component of multisystems atrophy. They get cerebellar involvement, and he's clearly got bradykinesia and decrementing bradykinesia. Now, one of the key things about the Parkinsonism that we see in PSP as well as multisystems atrophy is that it's symmetric. Now, one of the key things with idiopathic Parkinson's disease is that it's unilateral. It starts unilateral, over many years it progresses, but it's this asymmetric. Whereas PSP, which is primarily axial rigidity more than limb, but MSA is symmetric. It is a symmetric presentation. So this guy had symmetric decrementing bradykinesia, had symmetric rigidity. And so it seemed very clear that he was unfortunately developing multisystems atrophy. Now, the last one is corticobasilar degeneration. Now, that can, interestingly, present with a asymmetric presentation. But corticobasal degeneration is essentially cortical, so there's some sort of cortical involvement, and there's basal, as in basal ganglia involvement. So with the combination of the two, we get corticobasal. So cortical, we get a lot of sensory problems, corticosensory problems. So we might get apraxias, we might get 2-point discrimination loss, we might get agraphia, we might get very, very rarely your alien hand syndrome, which we've talked about. Your hand kind of moves around like you think it's an alien and you have to bring it down. And so you can get all these presentations in corticobasal degeneration. Corticobasal degeneration, you get myoclonus, you get apraxias, you get cognitive issues, and you get this Parkinsonism as well. Very rare, but you can certainly see it, and it's this combination, and specifically the apraxias and the myoclonus that you need to be looking for as well. And then the alien hand, which we won't go into too much detail. So first you look at the three ugly sisters, and then the next thing you want to look for is potentially vascular Parkinson's disease. So vascular Parkinson's is, I've got not millions, but lots and lots of strokes, tiny, tiny, tiny little strokes. I've also got lots and lots of small vessel disease. Now, if you remember, white matter lesions that we get from small vessel disease is not necessarily due to strokes. A lot of it is due to hypoperfusion and death of oligodendrocytes, which are cells that lay down myelin. And that's because of small vessels becoming atherosclerotic, getting blocked off, and they're hypoperfusing these regions that are deep within the brain and peripheral or distal to these small vessels. So in the process of developing all this ischemia, you're essentially knocking off parts of your substantia nigra and your basal ganglia, and so you get Parkinsonism. But what's interesting about this is they get quite significant upper motor neuron signs as well. Now you can imagine you're knocking off all these parts of your brain, specifically things like your coronal radiata or your internal capsule, which are parts of your upper motor neurons. So if someone comes in with significant lower limb predominant upper motor neuron signs or hyperreflexia plus Parkinson's that's symmetrical, you think vascular. And that's another mimic of Parkinsonism. Then we get into other causes like drugs and medications. So antipsychotic drugs, which are dopamine antagonists. And so they're blocking dopamine. And in the process, you can create or develop someone presenting with Parkinson's-like symptoms. Again, it's symmetric. And there's a very clear history of someone who's had very long-standing dopamine antagonist use. One way of trying to differentiating is doing a DAPT scan. So this is a dopamine, I can't remember what it actually stands for, DAPT. I think it's dopamine uptake, something. Essentially what you're looking for is a nuclear medicine scan looking at dopamine receptors in the brain to seeing if they're actually functioning in their uptake. Now, DAPT scans will be abnormal in any neurodegenerative cause of Parkinson's disease. But what they will not be positive in is medication-induced Parkinsonism. And so things like antipsychotics will come up as being normal on a DAPT scan. We can also have other medications like valproate, manganese toxicity can do it as well. And then we have rarer things like Fragile X tremor ataxia syndrome, spinocerebellar ataxias. But again, a lot of these are coming with other problems. They're coming with significant issues with motor tracts and cerebellar tracts as well. And sorry, one more thing to mention as well, which I've literally forgotten in this, is Lewy body dementia as well. And Lewy body is kind of on the spectrum of Parkinsonism, but it's really this predominance of alpha-synuclein and cognitive issues with sleep arousal, but you can certainly have Parkinsonism symptoms there as well. But the crux with Lewy body is the delusions, the hallucinations, Lilliputian, so hallucinating small people, cognitive issues, and sleep-wake disturbance and arousal. So in a nutshell, that's how we differentiate Parkinsonism from Parkinson's disease. So when someone comes in front of you, the first thing you just need to say is, do they have decrementing bradykinesia? So get them to do this test. See if they are slowly decrementing. You can also do the finger taps. I say make a nice big L for me, tap up and down and see if it gets smaller and smaller. And you do it on both sides. Is it symmetric? Is it asymmetric? Then I check rigidity, and then finally I check tremor, resting, postural, and then we do kinetic as well. And then if you can fit this into a Parkinson NISM, then the next question you need to ask is this idiopathic Parkinson's disease. Obviously do the rest of the examination, but idiopathic Parkinson's disease, is it unilateral? If I give them a dopamine trial, will they improve? Is there anything abnormal on the neurological examination? And if there's something else abnormal, then take a step back and think, am I dealing with something else? And review their drug history and make sure they haven't been mining manganese in Groot Island. Okay, fantastic. Monaco, did that hopefully answer your question? If you're still there? Okay. Monaco has left the chat. Okay, fantastic. Any other questions from anyone else in the audience? Pleasure. Okay. So I'll give it a couple of more minutes. I will check my phone to see if anyone's messaged me questions in the meantime. Okay. Well, if no one's got any other questions, I am happy to... Come on, people, you got exams in like 2 months. You must have some questions. Okay, why don't I go back to... Okay, could you please talk through interpretation of different EEG patterns? Okay, so how much detail do you want for EEG patterns, I guess is the question. Do you want to know just basics of EEG or like actual spike and wave and things like that? Or like I can let's just do it. Let's just go through the basics and we'll see. If you're happy with that, I will bring up the epilepsy slides. Give me a second. Basics and really what's required for the exam. Okay, perfect. Let's do it. Okay, let's talk EEGs. So EEGs, we're essentially just looking at your brain activity. That's all we're doing. So we're putting electrodes on your brain and we're seeing how those cluster of neurons are firing at that moment. Now, your entire brain is functioning in synchrony. It's working like a beautiful orchestra. And we have the conductor, which we'll call that the reticular activating system of consciousness, is allowing all of this to smoothly move in beautiful flow. So when we put the electrodes on, we put some on the right side and we put some on the left side. We're putting them over the lobes of the brain. And the two things that EEGs help us with are encephalopathy, to see if there's slowing of brain activity, and 2 is seizures. And within seizures, it's to identify, is there a generalized seizure or a focal seizure? And if there's a specific syndrome that we might see. So the first thing we look at is the actual rhythm of the patient. So this, we've stuck an EEG onto a patient. And so if we talk through it, we've got on the right-hand side, everything that is an even number is the right hand, and everything that is an odd number is the left-hand side. So for the right-hand side, you see there's F, T, so that's frontal, temporal, O is for occipital, C is for central, P is for parietal. And so these leads, each of these leads is telling you which part of the brain we're looking at. Right here in the middle is just straight down the middle, and then we have the same on the left-hand side. So each of these blue lines represents a second. And can you see how the brain is working in beautiful synchrony here, as the left and the right are moving in this beautiful rhythm? So we've got these up and down, these waves that are coming through. And what we do to begin with is we just count the waves. 1, 2, 3, 4, 5, 6. Let me put a pointer on. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So there's 11 beats in that little second. So we say that's 11 hertz. And so we can look and say, is this part of the brain at 11 hertz and is this part of the brain at 11 hertz? And if you were to count it, there might be some slight variations, but essentially it would be exactly the same because the brain is working together in perfect and beautiful synchrony. So the first thing we do is we check the hertz. So if you have 9 to 12 hertz, that's normal wakefulness. You're awake, you're doing your thing, you're doing well in life. You take too much benzos, so now you want to go to bed, you pop some benzos, but you actually end up getting beta, so you go to 13 to 15 hertz. You will feel drowsy, but it's this interesting phenomena where you have an increase in the amount of hertz when you have too much benzodiazepines. But let's say you fall asleep, you will drop down to 5 to 8 hertz. So this is what slow brain activity looks like. So if we take the same second, 1, 2, 3, 4, 5, 6 hertz now. So this patient is sleeping, or they're very drowsy. They're at 6 hertz, so we call that theta. So alpha is normal, beta is too much benzos, B is for benzos. Theta is drowsy, you're getting sleepy, and then once you hit 1 to 4 hertz, you're asleep. Your brain is still going at kind of in a synchronous manner, but you can see how there's significant slowing. Even the waves are getting a little wider as well. So we can use this to look for encephalopathy. Now, if you remember, encephalopathy is any sort of dysfunction of the brain. So this could be due to I've taken too much opioids, I've taken too much of my lithium, I've taken whatever it might be, and now I'm in kind of a semi-comatose state. I have taken too much of my sleeping tablet and now I'm in a semi-comatose state. Encephalopathy can also be due to my liver and I've got too much ammonia and so I'm in a drowsy encephalopathic state. It could be due to an infection. I've got HSV encephalitis and now I'm in a drowsy, confused state. And so what you see is slowing. You see slowing of the brain activity. How do you know they're not sleeping? Well, they're in front of me and I'm saying, wake up, Johnny, and they're not waking up and they've got slow brain activity. So they're clearly not asleep. They're in front of you, but they've got slow brain activity. And this can go from theta down to delta as well. So you can have people who are severely encephalopathic that have just got very slow background activity. So you can see generalized slowing, but you can also see localized or focal slowing. Now, I don't have a perfect image for this, but I want you to imagine that, let's just say the left side of the brain looks like this, and the right side of the brain looks like this. That would say there's focal slowing in a region, and that would suggest there's some sort of underlying structural pathology. Now, back in the day when we used to use leeches for medicine and we didn't have MRIs or CT scans, this is what they used to do. They used to put ECGs on patients, not ECGs, EEGs on patients, and they used to say there's structural abnormalities there because there is slowing of the brain. So when someone comes in with a stroke, and if you were to stick EEGs on them, you would see slowing in the region of the stroke. And you can say that part of the brain is just not working as well. So it's very good to look at generalized encephalopathy. It's good to look at focal regions of slowing as well. Now, the next one is to look at epileptic activity itself. So if we look at this patient, you can see the background is really slow, and it's really slow. There's only like 1, 2, maybe 3 or 4 hertz here, at the most 5, is because this patient is asleep. They're asleep, they're having a good sleep, and you can see right here, there is this sudden spike of electrical activity. And can you see how it is all beautifully lined up all the way through? So with it being beautifully lined up all the way through, this is an epileptic this is an epileptogenic this is epileptogenic activity. This is a spike of epileptic activity and the brain is firing spontaneously. We can see that it is generalized. It is happening, if I was to draw a line, exactly in sync with each other. Maybe there'll be a slight off second, but generally everything is firing at the same time. And then do you notice how there is a slowing of activity that occurs here? Now, what's actually happening is, if you remember the pathophysiology of epilepsy, the pathophysiology of epilepsy is this paroxysmal depolarization shift. What is happening is you have your resting membrane, it depolarizes, there's an overshoot, and then a repolarization, hyperpolarization, and then it stops. And so that's how a nerve or a neuron fires. This is how the heart fires as well. And that's normal. And you have to have this period of during repolarization of a refractory period, and that prevents the neuron from firing again. When there is a lack of a refractory period due to a pathology of some sort, then you just get continuous firing. And when enough neurons fire continuously, well, that's what a paroxysmal depolarization shift is. And that's what a seizure is. So when we do an EEG, what we're actually doing here is we're actually seeing this paroxysmal depolarization shift, and then we're seeing some level of a refractory period that's occurring, and hyperpolarization that's occurring here. So this is what we would call spike, and then the slowing is the wave that comes after it. So this is not a seizure, this is just epileptic kind of focus, or a little spike and wave. It's just one little bit of activity. Now, if this were to fire once, and then again, and then again, and then again, that's when you develop a seizure. And so if we were to have a patient in front of us with an EEG on having a seizure, we would see spike and wave, spike and wave, spike and wave. The entire screen would be spike and wave. Now, when we see a seizure, we can use this to actually narrow down what type of seizure it is. And very quickly, you can say this person has a generalized seizure. This person had a generalized seizure. If this continued on, this would be a generalized tonic-clonic seizure, or maybe an absence seizure as well, because those two are generalized seizures. So it helps us in that way. It can also help us figure out the syndrome. Now, there's tons of epilepsy syndromes, and the most common one that you need to know for your exam is your idiopathic generalized epilepsies or your genetic generalized epilepsies. And so same name, they're just interchangeable. And classically, these are the patients with juvenile myoclonic epilepsy, absence epilepsy, normal development, normal intellectual development, and then develop seizures in early childhood or teenage years, usually generalized tonic-clonic seizures, usually absence seizures or myoclonic seizures. And the pattern they have on EEG is they have 3 Hertz spike and wave. So they'll have 3 of these spike and waves within a second. So 3 Hertz spike and wave. And if you did photic stimulation, and I will demonstrate photic stimulation right now. So what we do is we do photic stimulation. And if you did photic stimulation, they would develop a seizure, and you would see this electrical activity occurring at that stage. So you can use your EEG. You can use the EEG to figure out, is it generalized, as well as can you narrow down the syndrome. Now, there's other syndromes like Dravet syndromes, etc. These are childhood epilepsies. I don't think you really need to know those specifically for physicians' exams. If you're pediatrics, then maybe yes. These have their own kind of EEG patterns, and a lot of those are what we say is encephalopathic epilepsies, and so they will be background encephalopathy. There'll be specific patterns. You don't need to know that. Now, the final thing we can look at is focal seizures. So this patient, you can see here, is having these spikes and they're having these slow waves. And here, do you see how there's a synchrony that's happening, but it's only occurring in one hemisphere. So this is a focal seizure that's occurring, and this patient's clearly having multiple seizures. And so this can again happen in syndromes like mesial temporal sclerosis. This can happen post-stroke. This can happen HSV, where someone's coming in with focal seizures. And this might manifest in a multitude of different ways, including loss of consciousness, focal motor seizures, or psychic seizures as well. So I think that's pretty much all you really need to know about epilepsy. The main things I would probably say is know your rhythms. So know alpha, beta, theta, delta. Know that alpha is normal, 9 to 12, and that if you're getting drowsy or sleepy, then it's 5 to 8 and 1 to 4, and then there's encephalopathy can cause that as well. And then know that seizures, know the phrase spike and wave, and then know that 3 Hertz spike and wave is prototypic idiopathic generalized or genetic generalized epilepsies. Okay, fantastic. Any generic tips on making a stellar neuro referral apart from working in Gegenhalten to the conversation? I'm going to be completely honest with you here. I have a very different viewpoint about getting referrals from people compared to what other people say. My basis is, if you want a neurologist to see your patient, just have a question and I really wouldn't worry about anything else. And I think anyone who gets angry at someone else for not doing a referral properly, just relax. Don't worry about it. Like, at the end of the day, it doesn't matter what the person over the phone tells you. You just have to go and see the patient and take a history and do an exam and do it all yourself once again. So I wouldn't worry too much, apart from saying, I've got a patient, we think they're Parkinsonian, we don't know why, they've got rip-roaring Gegenhalten, could you please come and figure out what's going on? I'd be happy with that referral, honestly. We're neurologists, we're here to help, what more is there? And if I asked a hematology colleague of mine, I've got someone that's got some sort of paraprotein, I don't know what's going on, I'm sure they'd come to the rescue as well. Okay, fantastic. Well, it's 9:55. Unless there's any burning questions, I'm happy to end it a little sooner. To Varanya 8107, were you happy with that EEG explanation? Any other questions you wanted to ask from that? Okay, fantastic. I will take that as a no. Varanya has left the conversation. So we will do this once a month. If you haven't already, go to the website basic-neurology.com. Description is in, I should put it in the description actually, now that you mention it. Sign up sign up for the newsletter. So once a month, I'll drop a newsletter, updates in the field, some interesting tips, something that, things that you need to know. Keep you up to date with the course information. Every month we'll do a Q&A. Send in your questions beforehand and I'll try to go over them as well. But once again, I'm more than happy to just do it through the chat as well. And just follow us on social media. And thank you so much. I think I'm happy with the very, very first session of this Q&A. Hopefully we'll get more people and more questions. But thank you so much for joining. I really appreciate it. Thank you so much. I just have to figure out how to stop the stream.